continuous appositional layer in the seromuscular layer. 2 different layers. All right. The good news when it comes to the stomach is dehiscence is relatively rare. No problem also with narrowing. When it comes to intestinal foreign bodies, these are a bit more of a challenge because now we've got a much narrower organ. You don't have that luxury of the voluminous space of the stomach. The advantage here, though, is those layers are a bit more adherent. So it tends to lend itself to a single layer closure. But before we get to surgery, I wanted to talk briefly about diagnostics. So how do you tell that the animal is obstructed? Well, the hard thing is the clinical signs that we see are highly variable. It depends on whether the obstruction is complete or partial. It depends on whether it's acute or chronic, and it also depends on the location. If the intestinal foreign body sits right by the cecum, there is almost the entire gastrointestinal tract available, so the signs can be quite mild. If it's up in the stomach or proximal duodenum, these animals will vomit violently, often projectile. So again, the signs can be varied, but typically we would see vomiting, anorexia, depression, even abdominal pain. When it comes to imaging, radiographs are often the first port of call. There is a nice study that says that if it's 1.6, if you look at the size of the intestine, if it's 1.6 times the height of L5, then it's going to be an obstruction. This paper, though, also tells you the grey zone. And in my experience, most cases fall into this grey zone. The other way is to look for 2 populations of intestines. So one gas-filled and one non-gas distended. And that can be another indicator. Sometimes you can actually see them, they're radiopaque, and we might see an associated obstructive pattern. You can use contrast. So you can use barium, for instance, hard if it's a partial obstruction. Or you can use those barium-impregnated beads. But again, they're not 100% sensitive or specific. So we've got to be a little bit mindful of that. Probably what I do as the mainstay is ultrasonography to detect a foreign body. However, I will disclose that I have specialists in diagnostic imaging that perform these abdominal ultrasounds. We know in skilled hands this is probably one of the best ways to do it, but in many situations it may not be so available to you. But ultrasound, if you're very skilled, is a very sensitive way to detect obstruction. And don't forget repeat imaging. So if you take radiographs every couple of hours and nothing is moving or changing, that's more suggestive of obstruction. If you can see the gas patterns constantly changing, it may be that foreign body is moving through. So each bit of imaging is just a single point in time. And then finally, if you've got consistent clinical signs, but you're still unsure, then you may decide that it's better to go to exploratory laparotomy, just like we said with dog bites. Don't be scared to go in and look if you think the consequence of missing it could be fatal. So exploratory laparotomy is still a very legitimate means of inspecting the gastrointestinal tract. So what do we do? Well, I'm going to talk in the biopsy lecture about the technique to find every part of this small intestine. I will tell you now that there is no hidden parts. Often the difference between good surgeons and less experienced surgeons is the knowledge of anatomy and to know how to access certain areas. I'm going to talk a bit more about that tomorrow when we talk about biopsying. How do you get to all those areas? But I want you to recognize that we should be following the gastrointestinal tract from stomach all the way to colon in one single maneuver. You don't have to drop it and pick it up another place. So we're going to run the entire gastrointestinal tract. We're going to look for the obstructions because sometimes there's multiple. So once you've found the offending area, then I'd like to exteriorize it. Now, the vast majority of cases you can exteriorize it, and then we're going to pack it off with lap sponges, just like we did the stomach. And this is important because if you perform surgery outside of the abdominal cavity and have minimal contamination, I don't lavage the abdomen afterwards because it's all exteriorized. So this is the setup that I would use here. Exteriorize, pack out with lap sponges. I then generally get my assistants to occlude that lumen. I get them to hold like this with their fingers, and then they can present both sides of that to me. Yeah. So I get my assistant to hold that off, and then if it's a simple obstruction and there's no loss of viability, a simple anti-mesenteric enterotomy, longitudinal, is the way to go. You should be able to go, in contrast to the stomach, through all the layers in one single incision. I use a new scalpel blade to do this because, again, this wound is critical. If it's not a clean wound, then it's going to be harder to suture. There's a higher risk of dehiscence. Scalpel blades are inexpensive, so I use generally a 15 blade and I cut right over that foreign body. If you can move it around, yes, we want to go into the healthiest area of intestine. Sometimes you don't have an option because it's stuck fast. So, to close the wound, you've got a couple of options. My preference for intestine is actually single interrupted sutures because I can control the tension on each individual suture. Continuous is appropriate, and it's been shown to be equivalent to single interrupteds in many studies. It's appropriate if you have an assistant that knows how to keep the tension on that. Because every time you let it go to take another bite, you rely upon your assistant holding the appropriate tension. I don't trust my interns enough to let them do that. But if I was operating with a very experienced surgeon, or if it was a very critical patient, again, continuous is appropriate, but single interrupted is my go-to. I take 2 by 2 millimeter bites, meaning I'm 2 millimeters from the edge of the wound, and I'm 2 millimeters between each suture. And this, in almost all cases, will give you an airtight, watertight seal. And this is imperative that we have an airtight, watertight seal. I make sure that when my needle goes into the tissue, it goes in perpendicular. I don't want to come in on an angle and risk missing a layer. So I'm going to come in perpendicular to that incision there. And when I tie my knot, I'm going to be very careful that, again, I don't put any lateral force on this suture. So I'm going to go in through the tissues, and often you may notice the mucosa everts. So you've got 2 strategies for that. Either you get the debakis and you turn the tissues back in to counter that eversion, or you get your well-maintained Metz and Balm scissors and you trim the edge. That's very appropriate. So they're the 2 strategies for everted mucosa. Often you will feel increased resistance as you go through that mucosa-submucosa layer. So if it goes through too easily, there's a couple of concerns. One, you've missed the submucosa or the strength-holding layer, or the tissue viability could be poor, and that could be necrotic tissue that you're trying to suture. So you will get comfortable with feeling some resistance there. And then I'm going to show you this little video here, and it talks about the tension and how I tie this knot. So what I like to do is to bring my edges together. I do a surgeon's knot, so that's 2 throws on the first pass. I pull it so the tissues come just together, but they're not deformed. Then on my second throw, it's a single knot to complete the surgeon's knot. As I tighten that, as you all know, that will pinch that suture down a little. So that's the tension that I'm using to compress those 2 edges. The first throw doesn't distort the tissues. The second will make it look a little pinched. So let's have a look at this video here. So we're in at right angles. Two throws here. We're going to get it so the tissues don't deform. Then we're going to tighten it. And the trick here is to make sure that knot stays in the same point in 3-dimensional space. You don't want to be pulling harder one way or the other. You want to make sure there's the knot, and as you tighten it down, you don't pull up or down, you don't pull left or right. You want that knot to stay in the same place in 3D space. So here, technique matters. So pinching just till the tissues come together. Next throw here, tightens it down, 2 throws on top of that, and that's my knot done. Okay. So there are a couple of variables when it comes to closing a wound. So the variables include the pattern, interrupted versus continuous, the suture material, and then the suture placement, how far away. So let's go through these one by one. So continuous versus interrupted, with an experienced surgeon, no difference in outcome. If you're inexperienced, or if you just prefer, I would do single interrupted because you can control the tension on every single bite. If the case is critical, it's okay to do continuous with a very good assistant. Now, what's the pattern that you use? Remembering there's a number of different ways you can bring tissues together. We can use inverting, everting, appositional, or crushing, where you actually tear through the outer layers. Which technique is best? Well, I'm including in this discussion here histopathology, because this ultimately tells us what happened. So, if we invert those tissues, you get a nice serosa to serosal seal. This gives you a lot of initial comfort that it's not going to leak. This gives you very high bursting strength. But what you've actually got is a little cuff of tissue that's running circumferentially around, if it's a resection anastomosis, and you actually have a little ulcer because you've got those wound edges within the lumen. It also narrows down the lumen, but on the outside, you can see the serosal surface, which is at the top of this picture. It's beautiful. So this is our little ulcer inside, because we've got inversion. The outside looks great. We don't narrow it too much here, but I don't generally recommend this. When it comes to the case of everting, if you have a look here at the inside, this is the lumen, here's the columnar epithelium, looks much better. But look what happens when you evert on the serosal surface, many more adhesions. And so again, this may be detrimental. If we look at appositional, now you can see this is when you just bring those edges together. You've got a nice clean serosa, and then you've got a nice continuous epithelial layer. So appositional is about as good as it gets when it comes to wound healing. Doesn't matter what it looks like when you close that abdominal cavity, it's what happens after as that wound goes on to heal. So appositional is ideal. The crushing technique, this is something that's gone out of fashion. This is where you just tie it tight enough so you cut through all the layers but the submucosa. You get reasonable healing, but it causes much more damage to the blood supply to those layers. So that's not something that we'll do. So I would recommend for intestinal surgery, single interrupted, full thickness appositional sutures. I like to use 4O polydioxanone on a taper needle. The needle matters, the needle counts, because if you use a cutting needle, you will create much more trauma and the bursting strength is lower. So it has to be a small taper needle, and I like to use 4O. The distance between the sutures and the distance from the cut edge, we've talked about that. About 2 millimeters. In very thick intestine, you might get away with 2.5 to 3. How do you know how far 2 millimeters is? It's the width of your DeBakey forceps. It's 2 millimeters. So you can actually have a look, and it gives you a visual clue. Each suture should be about the same width as your DeBakey's apart. And this way you can get very nice sutures like this. So this is what my mental cue is. I'm actually using my instruments as a bit of a gauge so we can get nice, even sutures. I do a leak test. You can inject saline. Often there's a whole lot of ingesta in there. So I simply milk some of the ingesta down to the site, I occlude it, and then we check for any signs of leakage. So that's all I do. There are other people that will submerge this in saline and look for bubbles. Generally, there's enough saline and blood there that you will still see bubbles if there's leakage of air. People have recently looked at probing, and they probe, guess what with? Mosquito hemostat that's about 2 millimeters wide, and you look to see if you can push the tip between the sutures. So again, these are really nice ways of helping you judge that distance. And that's been shown to be very accurate for predicting dehiscence. Said I perform all of this outside the abdominal cavity, so I don't do a full abdominal lavage. I just lavage the actual tissue outside the abdomen that I've operated on. And then I cover it with omentum. I don't tack that down and return that to the abdominal cavity and close. So that's how I would approach a standard intestinal foreign body. But little differences matter here. It's about how gentle you are with your tissues, and it's about having the right instrumentation and selecting the right needle and suture material. The less trauma you cause, the more success you'll have. Linear foreign bodies are challenging. We know the complication rates with linear foreign bodies are significantly higher. So these are string foreign bodies that cause plication of the intestine. In cats, they're often tethered under the tongue. This is a dog. Didn't read the textbook. But in dogs, most of them are tethered in the pylorus. So they're the two locations. Any animal suspicious with radiographs suspicious of a foreign body, check under the tongue, because you may get your answer here. This is what you may be faced with in surgery, and these are a challenge. So you don't want to release the tether until you're in the abdominal cavity. Because if you release that tether under the tongue, all of that will unfurl, and if it's perforated, then it's going to contaminate all the abdominal cavity. So don't cut the tether until you're in surgery like this. So that's what we removed in this case, and you can see this is the tether up here that was around the tongue in this case. The worst ones are the ones that are tethered and then they have a knobbly bit on the end. If it's just a straight piece of string with nothing at the end, generally the body struggles to really placate it. But you get this scenario, this really intense placation, when there's sort of a clump at the end, because the body can grab onto something as it tries to milk that foreign body through. Again, sometimes we see this laceration here. I know I said cats, but we do see a number of dogs here. It's just the trauma under the tongue. Okay, so what does it look like on imaging? Well, in dogs and cats, it's a little bit different. What we look for is the interrupted gas sign. So this is the interrupted gas sign here. You can see one bit of gas here, 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 and here. And that's very different to what we see in cats. Because in cats, you commonly see this. Can everyone see this? It's like a pearl bracelet or something. This is normal peristalsis in the cat. So that's not an interrupted gas pattern. Don't mistake that for a linear foreign body. It needs to be interrupted gas pattern, and that's most pathognomonic for linear foreign body. Now, can you just cut the tether and let things go? Well, it's been published. It depends on the cases that you see. In this particular study, they had 19 cats. The owners could not afford surgery, and so they cut the tether to see what would happen. Now, either it hasn't perforated and the string passes through, or it's perforated and now you've got a septic peritonitis. I quote this for owners, that if you do cut that tether at the base of the tongue, you probably have a 50-50 chance of that animal surviving. That's just based on one single study of 19 cats. It's certainly not something I recommend, but if it's euthanasia or giving this a go, then again, it's something that I would consider. But you need to be aware that if that patient deteriorates, you probably need to euthanize that patient because most likely it was already perforated. So, how we approach. Ventral midline. Isolate the intestines because we know that when they unfurl, we could get contamination. Then we release the tether, and that's either through a gastrotomy like this or under the tongue. And then once we've released it, this is what we see. So in this case here, multiple perforations all along the intestinal tract. So this was a very, very severe case, and this animal is actually euthanized. This is what we're looking for. So we're looking for cheese wiring of that foreign body along that intestine. Now, if you have multiple areas of perforation, my preference is to resect out that segment. But there's a limit to how much you can resect, obviously. Don't try and suture them. It's that tissue. It's like a traumatic wound. It's not been a sharp incision like we do an enterotomy. That's been cheese-wired through and traumatically ruptured. So don't try and suture those particular lacerations. If we need to do a resection anastomosis, you need to recognize that there are 3 points where you need to tie off the vasculature. So we need to take off the jejunal branch here, and then we need to take this arcade branch here on either side of the proposed resection. So the jejunal branch, the oral arcade, and the araboral arcade. Generally, you want to use an assistant, but you can use Doyen intestinal forceps if you don't have one. Okay, now, when it comes to how do you orientate your incision, generally go perpendicular to the long axis of the intestine. If you don't go perpendicular, then you have the option of making the mesenteric border longer or shorter. Now, because the blood supply comes from the vasa recta, these are the short, straight vessels, then you want to make sure the mesenteric border is longer than the antimesenteric border. So if you're going to obliquely cut it, This is the direction. Sometimes it's a strategy when we've got two different size lumens. Don't cut it this way, because this corner of tissue here, just here, will necrose away. So make sure that we're orientating that appropriately. Okay, so the challenges that we face. We mentioned everted mucosa. When you do a resection anastomosis, mucosa seems to continually grow. I trim it because I think it's very hard to see the lumen when you've got all this voluminous mucosa. So I trim that away with scissors, just like this. What I then do is I pre-place 3 sutures at the mesenteric border. The traditional textbook approach says you put 1 suture on the mesenteric border, 1 on the antimesenteric border, and then you've got 2 straight lines to suture. This is hard, and it's hard because there is all this fat around the mesenteric border where the blood supply comes in. And almost always when they leak on that mesenteric border. It's often the 2nd or 3rd suture around that fails. So the way to get around that is we pre-place the suture. So while I've got full access to the lumen, I take my bite on one side, the other side, but I don't tie it. I get a hemostat and clamp it. So now my 2nd suture, I can clearly see what's 2 millimeters along, and it's like the 1st suture. So this is what it looks like here. So you can see in the fatty tissue, I've been able to place each one of those very accurately. They're pre-placed and secured with a hemostat, and this gives me great confidence that they're well placed. And this changed my life when I started doing this, because particularly in fatty dogs, it's a lot less stressful where you can exactly see where you're putting that needle. So this is what it looks like, and you see that last suture is out of the fat. So the last suture here, that 3rd one now is out of the fat. I'm not trying to place that. Then I place my antimesenteric, and then I suture just like an enterotomy. So 3 to 5 pre-placed sutures on the mesenteric border makes a resection and anastomosis much, much easier. Again, it's 2 millimeter by 2 millimeter bites. Simple continuous like this. And then you can see we've got this little rent here in our mesentery. You need to close that. So I use, again, just the 4-O-monosin, fairly rapidly absorbing. Just make sure you don't damage the blood supply as you're closing that rent. We've seen cases of entrapment, so strangulation of another loop, when you don't close that. So it's important then to close that little rent. What happens when you've got 2 different sizes that you've got to join together? A couple of different strategies you can use. This first one from the textbook I don't recommend, and I don't recommend it because it creates corners. Corners are really hard, they're always a weak point. So I tend to use this other technique here, whereby we spatulate, so we can cut along an antimesenteric border, but I still find this doesn't give me a great shape or geometry. So what you might end up doing is trimming away those corners, but if you do that, essentially the situation you've got is this final version here with the angled cut. And that's why I mentioned that angle at which you cut it. The mesenteric border has to be longer than the antimesenteric border. So that's the actual technique that I prefer. So a slanted 2nd cut. Now, sometimes with intestinal foreign bodies, particularly a linea, we can see there's multiple perforations. How much can you take? The answer varies depending on the dog, but generally if you go over 80%, this dog is going to struggle. And that's why some owners may elect to euthanize the dog on the table, because at 80% length or more, they're going to have short bowel syndrome. They won't have enough length to have function. These dogs survive. I've done it twice. I don't think I would do it again, and I did it at the owner's request. But these dogs were both euthanized somewhere between 6 months and 12 months later because they became emaciated, that couldn't keep the weight on, chronic diarrhea. It's a really horrible way for these dogs to go. So then the question becomes, when you do an anastomosis, do you do a hand-sewn technique or do you staple? Now, my preference is hand-sewn, as you've seen, and I've taught you through that technique. But again, multiple studies show that stapling techniques are also very appropriate. Stapling can be faster, but the problem is it doesn't restore our anatomy. So whenever you do a stapled anastomosis, it's what's called a functional side-to-side. So what it looks like is this. So first of all, we take both ends, we put them into either arm of a gastrointestinal anastomosis stapler. You bring them together, puts 2 rows of sutures and it cuts between them. So I like to think of these as the 2 pant legs here. And then what you've got to do is use a TA or a thoracoabdominal stapler and cut it off at the top. So that's like the waist of the trousers. So ingesta has to come one limb, take a U-turn and go down the other. So functional side to side. And unfortunately, there are cases where material doesn't make it round the bend, and they can be a site where we do get obstruction and we can get sites of leakage. So this is what it looks like, the pants analogy, up one leg, across and down the other leg. But we know that in a large number of cases, additional sutures are required to have these seal. And one of the reasons for that is when you close a stapler, you are set to the closing distance of that staple. So that's set. So if you've got really thick tissue, then you're going to have a much tighter closure than if you've got very thin tissue. So when you're hand sewing, you can select that pressure. When you're stapling, it depends on how thick the tissue is as to how much pressure there is within that staple. So you've got a little bit less control, but it is significantly faster. So again, the evidence suggests that both techniques are appropriate, have similar complication rates. I guess my recommendation, and this is to all our residents and students, if you become good at hand sewing, you will be able to treat all the cases. If you get good at stapling, there are many scenarios, cats being one when their bowel might be very small, or if you're doing, for instance, a pylorectomy or other surgery, if you're not so practiced at hand suturing, then you're more limited to the array of procedures that you can perform. So it's something that's there, but not a must. There's a few other conditions I wanted to touch on before we move to question time. So intussusceptions are something that we see typically in young animals. There's always an underlying cause to this. Sometimes we don't find it, but we've got to look. So parasitism in young animals is probably the most common cause, but any hypermotility disorder can potentially cause this telescoping of one loop of bowel inside another. I never reduce them. I will always perform a resection anastomosis because the risk of recurrence is extremely high. Previously, it's been proposed that you would look at placating them, and I'll talk to you in a moment why that's not a good idea. Now, you may see this radiographically, you may see it ultrasonographically. So these are the diagnostic approaches that you take. Ultrasound, you see this target sign. In a radiograph, this crab claw appearance. Now, this is an example here of placation where you would take the entire gastrointestinal tract and join it together so it can't intussuscept. When we looked at this, the complication rates of this are higher than recurrence rates. And so what I perform is a resection anastomosis. I take out that abnormal tissue, re-anastomose, and we go looking for underlying disease. I always send that removed tissue for histopathology in case there's underlying disease, potentially neoplasia if it's an older animal, potentially they may note parasitism, but I always worm these patients as well. But we're looking for any underlying disease that's causing hypermotility. The other thing that we might see is neoplasia. Now, neoplasia comes in many forms. Some of these have an excellent prognosis. So if I have a case like this where I have a suspected neoplastic lesion, I take 8 to 10 centimetre margins. I'll biopsy lymph node. We'll talk about abdominal biopsies tomorrow. And then I'll submit that. Many of these may either be benign or maybe things like leiomyosarcomas that can have good survival time. So I generally do not euthanize on the table if I see neoplasia there. The prognosis can still be good. Now, if we have the case of perforations, then again, we're going to base all our decision making on those principles that we've already spoken about. We want to debride, lavage, close those wounds, provide drainage. So typically, if we have an ulcer like this, and this was due to non-steroidal administration, again, think of this more as a traumatic wound. Don't be tempted to try and suture that traumatic edge. Cut out that area and then suture together healthy tissue. If it's intestinal, then again, I don't try and resuture. We want to try and cut that out. So this is kind of the worst case scenario in gastrointestinal surgery, where you've done surgery and now you've got a wound that looks like this. So we've got pus coming out of the wound. Here we can see dehiscence. Now, often you don't see it initially because there's a lot of fibrosis. If you're looking for a perforation, look for the omental adhesions. They'll often lead you to where that leak is. So again, often it's at the mesenteric border here. This is what it looks like. I want to show you probing here. So this is a different patient here. And you can see too great a distance between our sutures. And these are the leakages. Don't resuture those. That's essentially a traumatic wound. Perform a resection anastomosis and remove that out. And this is the area that we've removed. Okay. This is that little dog afterwards. He was such a trooper. This was him the night of surgery. He was up trying to escape. And again, I just wanted to reinforce to you again the amazing work that we all do and the ability that we can change lives. This owner is forever grateful. He's come back multiple times with gifts of tremendous amounts of food. His gratitude was incredible. Okay, if you have contamination of the abdominal cavity, whether it be a dehiscence of a sutured wound, whether it be a perforated ulcer, for instance, again, what I like to do is I like to provide closed suction drainage to the abdominal cavity after I've addressed the underlying problem. So for septic abdomens, get a sample, lavage out that abdomen, treat the underlying cause, resect out the perforation or resect out the leaking anastomosis, resuture that. Then I put a closed suction drain in. You can pull this out the day after surgery if the dog's doing great, but often we regret not putting it in rather than regret putting it in. Time you may become confident in not placing a closed suction drain if you're happy that the abdomen shows minimal inflammation and you've treated the underlying problem. But if in doubt, Jackson Pratt closed suction drain is ideal. So the take-home messages. If you want to do gastrointestinal surgery well, you need good lighting, good instruments. You need suction, ideally assistance. It's more meticulous work than many of the other surgeries we do. You need to, again, move between the performance space and the learning space. Remember, practice is important. Every time you do a subcutaneous closure, think of it like an intestine where you need an airtight, watertight seal. Practice that precision and your closure techniques. I think that's important. And then my other take-home tip, the one that I think helps the most, is inner resection and anastomosis. It's a scary surgery when you have two ends of the intestine out like this. Pre-placing 3 to 5 sutures at the mesenteric border before you tighten them will make your life a lot easier. Okay, on that note, I'm really sorry there's no time for questions, but we're going to try and include them perhaps with tomorrow's talks. All right, thank you very much.